afternoon, everyone. Good afternoon. I am getting over a head cold, so bear with me. Let me go ahead and close that out. All right, perfect. Now, coming back, welcome to Intro to Holistic Medicine, week 4. Welcome in, welcome in. Let me go ahead and switch my screen. We are going to be working with ethical dilemmas today, biases, provider-patient responsibility, some case taking. We'll get into the stages of change and all of those different components that we have been discussing. Hello, 100 Packs. Thanks for coming in. So really quick, just to set the stage for our communications for today. I've noticed that hey, Cosmic Sunflower. I've noticed that those of you who have been in the communities, in the discussion, really talking about kind of this distinction or shift between, hey, rev up, conventional practice and holistic. And it is very much a mind shift. Hey, SJ, going from this very reactionary, hey, little sassy, conventional symptom-focused model. So I just want to reframe it because, and really help you guys to understand, that we've all been conditioned in this conventional medical model. That is, hey, Waverly, that is very symptom-focused. Because they are looking for symptoms to organize and diagnose, right? Pretty much label, so that then they can prescribe a pharmaceutical or a surgical intervention. The philosophy is that of treating an illness, right? Or treating a specific isolated event. So there's no correlation between this symptom relates to that symptom, which relates to a bigger, systematic issue. It's not really seen as that. It's kind of seen as isolated. So, it's okay if you break down on the side of the road. Everything else is fine with the car. We're not going to check the car out. We're just going to fix the tire. We're just going to fix, the oil. That's all we're going to do. And the patient has really learned in the conventional medical model to be very passive. I've had patients come into the practice for consultations over the years, and I'll say, okay, well, how can I help you? And they'll say, well, I thought you would tell me, how you can help me. And while I understand they don't understand what I can do to assist them, there has to be some connection to what is driving them to seek care to begin with. So if a patient is unconscious or neglectful or not paying attention to their bodies, it makes a very difficult case to address. But unfortunately, this is a product of the conventional medical model that views the patient as passive, views the patient as not responsible. The patient can just kind of come and go, and it's conventional medicine that's going to save and fix. Also, we know just from, I'm sure, experience, your typical time frame with a conventional doctor is only about 10 to 15 minutes, and that's driven by your insurance company, actually. That's not even driven by the provider. We bill out in units. Hello, Jackie. Hello, Mrs. Carey. We bill out in units when we are billing insurance. I no longer accept insurance because it's just a racket for both the patient and the provider. So the insurance will only cover 1 to 2 units of care. So, some patients' insurance will maybe pick up at 100%, maybe some at 20%. And I know patients think that doctors were just rolling in it. But my overhead expense on my practice when I was in family practice was $40,000 a month. And so I would be working incredibly hard to try to make sure that my rates were reasonable for patients, while also being ripped off by patients, while also overworking, while also constantly being called upon to address everyone's anxiety and nervousness and, oh my God, Dr. Steele, tell me, right? And so a part of that passive recipient of care and that, savior mechanism, and when I don't want a patient's power, I want a patient to be autonomous. I want a patient to actually learn their body and learn what they need to do with their body. However, many patients did not like that idea and wanted me to kind of be in the, constant. And I as a doctor, you can't work 24/7. It's not healthy. And through COVID, it was really insane because of all the misinformation. We are in another Trump presidency, so we know that there's going to be a lot of public health miseducation, which is why I wanted to kind of get started already and really get people educated so we can stay more grounded, right? Because the media is designed to create illicit fear. So, as a for instance, the media is discussing measles. Hold on 1 second. So measles, is definitely, a contagious infection that we must be mindful of, right? However, notice that the only conversation of how to prevent the spread is a vaccination. There's never a discussion about how to support your immune system. So there's never a discussion about high-dose vitamin C, zinc. There's never a discussion about various different antimicrobials that you can take prophylactically. There's never those kinds of discussions. So even during COVID, we were, doctors like me were just losing our minds because we were passing information across the country because we're quote unquote data doctors. So we take our own data. We're not dependent upon the CDC. And so our data wasn't matching up with the data that we're being told. And so, and then we're speaking out and then we're being suppressed, and so that's when we went from Facebook to Clubhouse, and we would run 24-hour rooms on Clubhouse, educating people about, the various different components that they need to be aware of when it comes to their health and their healing. And so we're very much in the same instance. There is no institution that's going to come and save us. There's no doctor that's going to come and save you. There's no one that's going to come and save you. You're going to have to learn how to treat your own body and how to heal, especially in your communities. So in conventional medicine, it's very limited when it comes to prevention. It's mostly reactive, so there is no conversation of what you do to support the immune system. For instance, usually in about September, October of every year, we contact our patients. We give them, kind of pre-cough, cold, and flu season protocols to stabilize their immune systems, and we educate people to be, again, proactive instead of reactive, right? Why do we do that? Because it's much easier to support the body's natural ability to heal itself rather than constantly assuming that the body is prone to failure and always needs external intervention. And so that is really how conventional medicine views the body, as broken and is needing always external intervention. And there is a lot of reliance on tests and scans and pharmaceuticals, but not necessarily a correlation between those particular technologies and an advancement, hello roller girl, an advancement of life, quality of life or life expectancy or any of those things. So we find that when conventional practice utilizes technology, that they're not really utilizing the full aspects of technology that can, really be utilized. And then naturally in conventional medicine, there is always a separation between the mental and the physical and the spiritual. So now let's look at holistic medicine, right? So we know conventional practice, we've done it, we've looked at it, we've studied it, we understand it, we've grown up with it. Now let's kind of shift this mindset into root cause. So instead of symptom focused, right? So when a symptom comes up, we always ask ourselves where it can be coming from. Also, we don't ignore symptoms. So in conventional medicine, you tend to ignore what your body is telling you until it breaks down to the point you can't ignore it anymore. We don't do that in holistic medicine. Hey, black is beautiful. Instead, our treatment focus is more preventative. We view the body as an interconnected system. So mind, body, emotions, environment, spiritual aspects, ancestral, all of this is part of an interconnected system that really puts the patient in the driver's seat of their own healing process. So my role is to teach patients and facilitate patients in their own ability to heal themselves. Now, with that being said, I tend to spend longer times. My initial consultation is about an hour long. In classical homeopathy, they do 2-hour consults. It's just not practical in my style practice, but we do hour-long consultations, and then typically follow-ups are about 30 minutes. And the focus is on prevention. So when I'm seeing a patient, I'm also assessing for what things we need to be looking out for, whether that's bone density, whether that is thermography, whether that's their hormones, whether that's their nervous system. We're always looking for, ways to get ahead of things before they become a problem. And that's because we believe that the body is an amazing self-healing organism that can and will heal itself if given the right environment. And so we leverage technology such as functional lab testing, genetic lab testing, and your basic biochemistry and remote patient monitoring to help us determine exactly what's going on with the patient, hello, peace, and what needs to occur. And so as we are doing that, as we are, evaluating the patient, we're able to create really customized treatment plans and work with patients. And the treatment plans integrate all aspects of the patient. So mental, emotional, spiritual, environmental, etc. I always like to say patients come into my office and they dump their lives on my desk, and my job is to organize them. Hence why I have a lot of education in a lot of different areas. So this is kind of our setting this stage for what we're going to kind of go over today. Just so you can begin to kind of see the distinctions. If you're in the Intro to Holistic Medicine class, you should be in your community group by now, whether you are interested in holistic health coaching, holistic lifestyle, which is just incorporating a lifestyle for you and your family, or pure black, you want more of an Afroindigenous viewpoint. These are our 3 community groups that we have, or we'll be hosting our discussions in between class, as well as replays for any of the classes that you've missed. Today's class is ethical decision making and data-driven holistic care. So by now you should be have completed your nutritional assessment questionnaire. That's your subjective data. Hey, melanin, and totaled that up. And then now you should have gotten your pH strips and at least began tracking those. You can track those with the metabolic guide in a print form, or download the Holistic Life app and track it through there. So we're going to be using those data points as we're moving into part 2 starting next week. Part 2 begins with nutrition. So we'll be focusing on your nutrition next week, and I'll be teaching a lot about nutrition next week, from very simple meal planning to prepping macros, all the things. So today, our course objective is understanding ethical considerations, because it's not just, one size fit all. There's going to be a lot of nuance that we'll go over. We will also learn how the data tracking enhances holistic interventions. Excuse me. We'll explore the connection between ethics and the stages of change, and knowing, when and how and why to initiate change with a patient. You'll be able to recognize your own bias and assumptions in holistic decision making that we all have to check within ourselves. And then analyzing ethical dilemmas through various cases. I'll tell you about various cases that I've treated over the years, kind of the good, the bad, the ugly, just so you learn a little bit more. And then we'll talk about the roles of the provider's responsibility versus the patient responsibility, so we can clearly define each other's roles. So let's go ahead and start in with ethics in a holistic practice. So why does ethics matter? Okay, why are we ethical? Hi, Bianca. Because it provides trust between you and the patient. It also provides transparency between you and the patient. If especially if you're working with patients with trauma, if you are not transparent with, let's say, your scheduling, your fee schedule, etc., if you're withholding anything, the patients are going to pick that up because they're very intuitive. They're very sensitive because they've been through trauma. So it's important for, if you're going to work with a patient base that has been through trauma, that you are trustworthy and you operate with integrity and you're able to be transparent, right? So if you have anything kind of lurking in your past that prohibits you from being transparent, probably want to stay away from trauma patients. Also, to accountability. So ethics matter because they hold yourself accountable, and then also too, they hold other people accountable. And so making sure that each party is bringing their part to the table. Otherwise, if you're because it's a relationship, so it's a back and forth. So otherwise, you're either going to be doing too much work, you're going to be putting too much effort in, or they're going to be doing too much effort. So you want a balanced effort. You don't want to be doing too much, and you don't want them to be doing too much. It's really a balance of support. And this has taken me, honestly, years to work on and determine, because in the beginning, I was very much Operation Save a Hoe. Out of my own wounding from the past and need to be saved myself, I in many ways acted out trying to save other people, until my former husband passed away of bladder cancer, and I realized that I couldn't save people from themselves. It's a very difficult lesson, I must say, but one that was very much needed because of the unhealed trauma within my Afroindigenous line and some of the survivor guilt that my people had felt. I had carried that wounding into this life and really was trying to save people because, my own people were not saved. And so we want to be very careful of any transference that comes up. This is why if you choose to go into this to help other people, that you really keep a check and balance in place for yourself, i.e. you're working with someone yourself, even if it's just a therapist or somebody of that regard, just to keep you organized so you keep your ethics intact. It's very easy to have transference in a relationship, especially the longer you've worked with the patient. Number 2, informed consent. So patients must understand all different things. They need to understand what your hypothesis is, which is your educated guess, what's going on with them, what your proposed treatment plan is, any risks, any benefits, and then of course any alternatives. So they should be provided, what the conventional methodology or treatment protocol would be, to be given them options to, go that route if they want to. Now, unfortunately, on the other side, conventional practice is very ignorant to holistic practice, so they tend to not make recommendations unless you've established relationships with conventional doctors, which I'll show you how to do eventually. Okay, so the next is autonomy. So patients have a right to choose their care. And this is really can be challenging because you could absolutely know in your heart and believe that you can help this patient. But maybe that patient has so much fear around their own healing, and they have so much, anger because they, were victimized or traumatized or whatever. They may not be truly ready to surrender that type of control and allow for their own, healing. And so that's something to be mindful of as well, is that so the responsibility begins and ends when the communication leaves your mouth. So once you have stated, what your what your evaluation has come up with, what your treatment plan recommendations are, what the potential risks and benefits and all of that, alternatives. Once you provide that patient that information, your responsibility is done. Their responsibility now has to pick up, and they have to actively choose care. So I'll give you some examples. So I'll have patients who, they get triggered emotionally when they are not well. And so they will reach out, almost kind of hysterical, emotional, in tears, right? And so in the past, I would, go in and they'd send me a text and I'd be like, oh, are you okay? And how can I help? And I would pretty much be laboring for them in between appointments. And, they felt much better, whatever, but what would happen is I would be feeling drained. And the reason I would be feeling drained is because, they would have their set appointments, and maybe they would do what they needed to do, or maybe they didn't, but they would be reactive in between appointments. And instead of learning how to sit with their reactivity or learn, what their emotional dysregulation is telling them, they would want to kind of reach out and hit the Dr. Steele button. And so thinking that hitting the Dr. Steele button is going to move it faster for them, or that they're going to get, better, easier, or whatever, they're going to get some sort of leg up. And so I had to really learn patient boundaries, because I cannot continue to sustain continuing to self-abandon and give to them, even if they were not necessarily practicing their own autonomy. We also have to see the patient as already healed, right? We have to believe that the patient is mentally and emotionally and spiritually well enough to make their decisions about their health, right? And if they're not, naturally, they need to have a healthcare advocate that is available with them. And you, as an ethical provider, also would want to, hey, Google, would also want to, be able to communicate that between the two. Making sure that you state where you are, and then you create a space where they can heal if they choose to, but you're not going to run in and do all the things for them. They have to, come forward on their end. Non-malevolence. So we want to make sure that we do no harm. That can be easier said than done, believe it or not. When we move too fast through things, we can do harm inadvertently. That's why in conventional medicine, it's like to call it linear. So it's like A plus B equals C, and that's kind of the way that it's viewed. Whereas we know in holistic medicine, A, square root B, D, divided by the E, there's so many different variables. So we have to move more slowly and we have to move more methodically. And that's really where our data guides us. Because especially in the beginning, you're not going to have the experience in knowing patterns. I'll teach you patterns, but until you experience them yourself, it'll be difficult to recognize them just realistically. So eventually, as you become a better practitioner, provider, etc. And also, as you have healed different aspects of yourself, you'll be able to fully communicate, with the patients, what they can expect. Otherwise, you're just going to be somewhat, either regurgitating, stuff that they already know, or you're going to, be fawning all over them or be afraid or whatever. So we want to really build this very confident, structured clinical world where we're not reacting. Thank you, Medusa, for liking, where we're not just kind of reactive all over the place. So we'll get into it. And then naturally, there has to be justice between the best interest of the patient and equitable care. Sometimes that can be a little challenging, especially patients that want more and more and more, and then also too patients that have had injuries from the conventional medical system. I think that always to me is probably the most difficult. It is the third leading cause of unaliving is through medical errors, but based off of superiority bias and confirmation bias, it's assumed that they know everything. Unfortunately, they don't. They know very little. They know what they know, and everything else is kind of blasphemous. And there's just this model where unless you are a conventional doctor, an MD, a DO, an NP, whatever, it's perceived based off of the bias that you're nothing, you're nobody, you don't know what you're talking about. So it can definitely play on your psyche as a professional, because you're fighting to be acknowledged and accepted. And it really doesn't matter how many patients you've helped through chronic conditions or how many successes that you've had. That suppression in holistic medicine is very much still real. And so really doing this, not for financial gain, but really, doing this as a, real act of defiance in the revolution. The healthcare system is failing. It's been failing, and it's definitely not going to, just fix itself overnight, especially not under this administration. So one of the things that we use often to kind of keep us in check is data, right? So remember, we don't guess, we test. And we do this, and, I started off doing very generalized testing, your basic lab panel, whatever, do a food diary, whatever. And then over the years, just really started building out just a robust list of testing, and data assessment. Not everything is testing. Some of it's remote patient monitoring. And so that way it allowed me to look at the patterns and triggers that were associated. So I've treated over 40,000 patients, and watching their track data, most of the time, patients coming in, they don't eat enough protein, they don't eat enough carbohydrates, and they're over consuming fat. How do I know that? Because I've seen it time and time and time again. It's something that I've seen thousands and thousands of times. And those people are like, oh no, it's not that. And then, they argue with me about tracking, and then we finally get them to track, and then they go, wow, you were right, And so there's experience there of working with people outside of myself. Okay, so working with myself is one thing, but then working with other people is a whole nother thing, because then you have to be able to, hey, Medusa, thank you again. Then you have to be able to separate yourself out from, the information to be able to be objective, to be able to support the patient. And we have to look for evidence that we can replicate so that we know what we're doing. So in this case, what we're working with right now is our pH levels. Eventually, not next week, but the week after, we'll be getting into heart rate monitors. So next week we'll talk about the heart rate monitors. You can get one off TikTok Shop for like $20. So, and they're little rings or whatever. So we'll talk about those next week. So you can make sure you get those for our stress management week. And so when we're looking at our data points, again, we don't just assume. So patients will be like, oh yeah, I'm eating healthy. And if you go, okay, sure, and you take them for, their word, and don't verify it, you're not doing them a service and you're not doing yourself a service, which means that you have to be really good with confrontation, simply because there are going to be things that you're going to talk to with your patients that they're not going to like. Right? So because they've been doing it a certain way for a certain period of time. And so when you start challenging that and holding them accountable, the ego no likey, right? So they're going to be like, you're going to say, okay, you need to track your food. And they're going to give you 1,001 reasons why they can't track their food. Oh no, I can't do this. It's too much. Technology. Oh my gosh, it's so stressful. I don't know what this is. I don't know what that is. Because why? It's all change, right? The nervous system and the brain is all having to endure change. And so the brain is going to go, no likey, I don't want change. Who said we're doing change? I didn't authorize that. And so we have to be aware of where that patient is in the stages of change to be able to determine what the best thing for them to do in the moment, and also the next step. Because remember, you don't have to do everything overnight. This is not reactive care. This is very proactive care. So as we're looking at these ethics and our stages of change, remember our stages of change are that first pre-contemplative. So a lot of times in pre-contemplative, hey, Cron, that patient is really unaware that they actually need change. They're not quite in denial because they're at least aware that there's something that maybe needs to be addressed, but they haven't really spent any time actually assessing those things. So they're in pre-contemplative. Those patients you really don't want to be spending a lot of your energy and a lot of your time with, simply because they don't really know. Right? They don't really know if they're ready. They don't really know, and what'll happen is if you do spend your time with them, they are going to maximize your energy, meaning they're going to want you to explain everything 10 times over, and they're going to pretend like they don't understand because they have a secondary gain that's in their subconscious that's holding them back from being able to truly move from pre-contemplative to contemplative. So they're not quite ready to let go of whatever was holding them back to begin with. So we're not going to, waste a lot of our energy or our time on those people. The contemplative, they are considering change, right? But they're still a little squeamish, right? And so it's important to listen for these clues in communication. That's why I really want you guys to connect with a partner in the groups, because I want you to start listening for when a person's in pre-contemplative versus when they're in contemplative versus when they're in preparation versus when they're in action, etc. We're listening to reliably deliver that which makes a difference. Because if you have an Operation Save-A-Ho, right, and you're thinking that everybody wants to be saved, you're going to be rushing out there trying to help everybody, and you're going to burn yourself out really quickly. Because even if people come into your office, even if they pay you, doesn't mean that they want true help and they want true transformation. And I know that may sound crazy, but some people just want attention, okay? So for me, I have like kind of this like goddess earth mother sort of vibe for people. And so if people have mother wounds, oh my goodness. So then they literally, I will watch 45-year-old people turn into toddlers because I tell them no. And they will literally stamp their feet. They'll get emotional. They'll want me to kiss their boo-boo, make it better. And here's the thing, as an ethical provider, I cannot do that, because they need to learn, just like a child, they need to learn how to manage their own emotional wounds. So it requires a lot from me as a provider to make sure that I don't allow my empathy to go unchecked, and I make sure that I keep a healthy therapeutic relationship in place while also facilitating, that patient's own self-determination. It can be really challenging not to want to take away a patient's power and their own ability to heal themselves. We do not know better than that individual what is good for that individual. Even if we think we do, we don't. It is not our life. It is not our role. It is not our place. I'll leave it there. So when a patient is in true preparation, they're ready for change. They're actively seeking you out. They're actively asking questions. They're more engaged. They're not as internalized, right? In contemplative, they're going to be far more internalized. They're going to be trying to figure stuff out. It's not going to make sense. Even if you try to explain it to them, they're going to talk in circles 1,000 times. You're never going to get to a resolve, right? Even if it's the same thing. So you can't, you can't save everybody here. Preparation, again, is the best, because now they're actively seeking. They know they have something to work on, and they're ready to embark on that journey. So really, those preparation people are your sweet spot in addition to your action people. So preparation, action, preparing to take action, and those people are in action, are naturally doing the things. They're eating the food, they're drinking the water, they're moving their bodies, etc., right? And then they move into more of this kind of maintenancing phase where it's becoming more of a lifestyle habit. And so we also have, what's not listed on here, is relapse, right? So relapse people need you because they have a blind spot of sabotage. They'll do well for a short period of time, and then they'll sabotage themselves. So what we want to unpack is not the actions, because it seems like the person knows the actions. It's what's underneath the actions. It's what's driving the actions. That's the issue that needs to be addressed. So take that into consideration, that our ethical responsibility is to assess a patient's readiness, and be able to not give them too much or too little care. So it's very much an art form. All right, so we're going to look at a couple case studies. Let me make this bigger so I can see. Okay, so our first case study that we're going to kind of do, and I'm sure I've had many of these in my life, is a patient refuses the recommended treatment. So what do you do if the patient refuses recommended treatment? Go ahead and put it in the chat if you have an idea. A patient refuses a recommended treatment. So you come in, they do a consult with you, you assess their case, you give them the treatment plan, and they tell you no. They go, that doesn't look good. I don't want to look at that. Dr. Oz says... Dr. Fauci says, or not even Dr. RFK Jr. says, my Facebook group says, people will get creative, let me tell you. So what will you do if a patient refuses the recommended treatment? I'll give you a couple minutes, see if you respond. Otherwise, we'll move to the answer. No takers on that one. All right. So if a patient refuses recommended treatment, you can't do anything, right? Remember, the responsibility begins and ends once it leaves my mouth. So we have to hold our patients autonomous and accountable. So naturally, we're going to tell them, why our recommendations are the way they are. It is their right to refuse treatment. The possible things that happen that can happen as a result. Now, you're not going to give them a fear speech, right? There's no intimidation. They get that enough in conventional medicine. They're told, if they don't do this or that, then this or that's going to happen. And we don't have a crystal ball. We don't really know what's going to happen. Nobody knows. Even the conventional doctors do. You should see them in end of life cases, and I mess with them. So I go, hey, when do you think the patient's going to go? And they're like, we have no idea, but where's a code? We need to go get some adrenaline. Meanwhile, I'm, over there chanting and, sing-songing on, the patient's heart, trying to get him to move on. So, the thing is that if a patient decides that they are ready to get well, then you are available. If a patient says, no, it's not you, maybe, just maybe your role is just to plant the seed. Don't take it personal. I know that can really be challenging, especially when you put your blood, soul, and everything into the work that you do. However, this is where that balance and those boundaries come in, and equitability in relationship. You can't give more than you're receiving. Case number 2. A provider believes in a natural remedy that lacks scientific support. So I see this all the time on the social media, where people are promoting supplements that have not been tested, that are not GMP certified, which are good manufacturing practices certified. And also they're just, it's one size fit all for everybody. So everybody's going to take this detox program. Everybody's going to take this supplement. There is no actual scientific method. It's just you're selling supplements online. And it drives me nuts when I see it, because I know that person's only motivation is to make money. It is not really to do a quality job and to ensure that they're not doing any harm to the patient. I've known some, popular influencers that don't even take medical history, and they are giving out herbs to people. They don't take medication information, and they're giving out supplements and things like that. Again, very dangerous, because you don't know, what you don't know. And so you could, be giving the patient something that can make that medication work better or worse. A good example of that would be St. John's wort, right? So St. John's wort is often used as like a mood stabilizer, and many people will use it for that. But if you're on a psychotropic medication, i.e. like an SSRI or something like that, it can actually make your SSRI ineffective. So a person that doesn't know that, or they don't assess for what medications they're on or what the patient's goals are or whatever, wouldn't be aware of that, and then they just kind of make a recommendation willy-nilly, not knowing that now they put that patient's life at risk. And so here's the deal. If your patient, so I'll tell you this one case I had. I'm going to turn the fan on really quick. Because, still like 1,000 degrees in the Caribbean. All right. So I'll cool myself off for a minute, and then I'll turn it back off. Okay. So I'll tell you this one case I had. I think I was probably like 4 or 5 years into practicing. And I had this patient come in. Patient was in her mid to late 30s. She came for weight loss. She was doing well. She had a supportive, loving boyfriend. She had a supporting, loving family. Like, everything was good. She was following her meal plan. No big deal. Then all of a sudden, her tongue started to swell. And obviously we knew it was an allergy of some sort, but we couldn't figure out why. At the same time, her dad was hospitalized and tragically passed away from a medical error. The doctors gave her dad the wrong medication. He had an allergic reaction to the medication, and he unalived. And so this patient was like daddy's girl for sure. And so she just could not recover emotionally. And now remember, we're dealing with a swollen tongue, right? So now we're dealing with grief and the swollen tongue. She's lost the weight, but now she's like, it's almost like she's losing too much weight, right? So I'm like, okay, so what's going on here? You know, probably there's some depression, there's some sadness, you know, whatever. But, you know, she's losing weight at an unhealthy pace. And we still have the swollen tongue, and we've run all these labs, and we can't figure out what the allergen is. So I'm concerned about her electrolytes, her hydration, all that kind of stuff. She's getting lethargic. I send her into the ER. To make sure that, you know, she's got fluids and all that stuff. The ER turns her away. Not once, not twice, but 3 times the ER turns her away. So the last time, you know, she went home again, she's not well, whatever. Her boyfriend calls me in a panic, has me come over. I come over, I check her. She's kind of listless, lethargic, whatever. You know, she's going to take a nap. Okay, once she gets up from the nap, we're going to go back to the ER yet again and try to see what we can do, right? So, all right, I leave, you know, after I check her vitals, make sure she's at least stable. We have our treatment plan together, because this was at the time I used to do house calls. So this is so old ago. All right, so then we're good to go. Boom, I get a call probably, I don't know, several hours later from the police to let me know that she's no longer with us, right? So then the medical examiner, right, and the hospital are trying to point the fingers because they're trying to avoid liability. So now they're pointing the finger at me. There must have been something that I did, right? Even though I sent the patient consistently to the ER and they did nothing, right? Now all of a sudden it's my fault, right? So here's the deal, right? So you're working, you know, and I'm still the doctor, so I'm working with their family, because now this bright, vibrant 30-something-year-old woman has now passed away unexpectedly. So I'm working with the family through their grief, the boyfriend who's hysterical, right? The police now who's interrogating me like this is an SVU case. The hospital who, you know, is literally just trying to, you know, push off their own responsibility because they ignored the patient and didn't follow anything that I was saying. And so because of that, they cost that patient their life, and, you know, they don't want that on their record. So they're trying to, you know, get rid of it. And so here's the thing, right? Because my practice is structured the way it is, and because I follow practice, and because I follow a protocol and a regimen and all of that in a structure, I have C-wide aid, meaning that I'm good. I can repeat the case multiple times. I know the case inside and out. All, you know, when they picked up all my chart notes, all my chart notes were in order. And even at the end, the detective was like, well, you know, do you still kind of know, you know, what happened? And even to this day, many, many years later, still have no idea, other than the fact that, you know, her father passed away, and that grief I don't think she could have overcome. And so it's important, right, that you keep proper records, and more importantly, that you are following scientific order and a scientific practice that I'm showing you. All right, case study number 3. A patient wants to stop conventional treatment. How do you navigate? Okay, so I call these the Hail Marys. So a lot of times the Hail Marys will come because they have spoken to their oncologist or their conventional doctor, and they've been told things that they don't like, okay? And so they come to my practice now looking for the Hail Mary. They want some sort of, you know, herb that I've dug up from somewhere that's going to make it all go away, or some sort of supplement, or, some sort of, I don't even know what they expect. I don't know. I'm supposed to chant or something, and it's supposed to all go away, right? And so it's about properly educating the patients to let them know, hey, holistic medicine is magical, for sure. But it's also, it's about you and the patient, and there's all these different factors. So how do I navigate? Like I navigate every single case. I don't treat patients with terminal conditions any different than patients that, are brand new to the world, right? Being in family practice, I worked with patients that hadn't even been born yet, all the way into, patients that took their final breaths, right? And everything else in between, and was there when they took their final breaths. And so, the thing is that I follow a structure and I follow a system regardless. And in doing that, you'll be able to navigate the patient appropriately. Remember, what do you think? What do you know? What can you prove? Right? And remember, this is the highest good for the patient, okay? Whatever that looks like. So it is a practice and it is a process. And so definitely follow the structures that I provide to you, because they have been utilized and they have definitely been tested. I have been put up on the paces of all different components, and to develop this very structured scientific approach to be an ethical approach to help patients get well. So the discussion that we're going to look at is, how do you balance your personal beliefs with ethical patient care? So I may have some personal beliefs about certain things, but that cannot, cloud my judgment, or definitely I need to make sure that I'm responsible and respectful, because even if a patient, let's say, isn't into, my same practices, I still need to be respectful to them, because again, patient autonomy and patient choice. So what I think is not always best for the patient, even if, I am the big I am, all my education, blah, 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 I still have to realize that at the end of the day, people are going to do what's best for them. I've had patients come to me looking for a Hail Mary, and I've had to literally, like, several patients had to be like, look, I will not see you until you go back to your oncologist. I will not see you until you come off of these medications. I had one case of a child. The child was 5 years old and was a ADD, ADHD case. And they continued to give this baby multiple psychotropic medications. So they gave her one set, then they took her off. Then they gave her another set, then they took her off. And they gave her another set, took her off. And I already warning the mom, you can't do that. You can't keep changing the protocol neurologically. It's going to affect the patient. It's going to affect the patient. Going to affect the patient. Nobody wants to listen. So then all of a sudden, patient now, 5 years old, is homicidal. Patient now has knives and is threatening mom, okay? And because the patient has been giving multiple psychotropic medications and has not titrated off of any of them, and now their neurotransmitters are all over the place. So now I have to say, look, I'm either going to recuse myself from this case entirely, or you have to take this patient off of all the psychotropic medications so I can rebuild this patient's neurotransmitters, okay? There's no other way in between, right? Because now the conventional practices mess this little baby up so much, and another hospitalization is not going to do it. So in that case, I had to really take that firm line. I'm grateful that the providers and the mom listened to me. We were able to take the patient off of all the psychotropics, rebuild all that back. I think we only had to rebuild like 2 psychotropics back. But now the patient's like in her teens, and she lives in Florida now and is pursuing acting and all kinds of stuff. So, however, again, sometimes you have to take a stand somewhere with these cases. When I had moms coming to me who had reactions after the MMR inoculation, and, you know, their pediatricians are trying to pressure them to keep going and keep getting more shots even after they had seizures or learning delays. You know, again, I had to stand up speaking truth to power to make sure that ethically, you know, these providers know, wait a second, there's an injury, even though you don't believe that it's valid or it's related or whatever, you know, this is what we have to do to make sure this patient is safe. All right, so naturally, right, not everyone's going to be super open. We have all different types of biases. So there's, which I didn't put on this slide, but there's superiority bias. Superiority bias is one that believes that conventional medicine is better than natural remedies. That's because, excuse me, majority of the spending of research is done on pharmaceuticals. Not to mention the fact that the pharmaceutical companies also pay the peer reviewers quite a bit of money to skew the studies. So quietly, Pfizer paid out about $60 million last year in October 2024 to peer reviewers because they were paying them off. So what that means is that our healthcare information that we've relied on is biased and skewed. Not to mention that the CDC actually has patents and they make money off of certain recommended treatments. So there's a real conflict of interest when we have the same institution that's responsible for studying the efficacy of a particular treatment is also the one who is making the recommendations and holding the standards of care in place. That's not an effective check and balance. That actually is very flawed and very dangerous. But most people don't know that. And so again, superiority bias and then also confirmation bias, where people only seek evidence that supports their personal belief. So if I believe that holistic doctors are just a whole bunch of quacks and hippies, I'm going to not listen to anything that they have to say, even if it's medical, even if it's totally sound logically. I'm going to totally dismiss anything that they say, and I'm going to then immediately call them names, immediately say that they are, quacks and not real doctors and blah, 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 blah. Because the evidence that they are presenting conflicts with my personal belief, which means it conflicts with my confirmation bias. Another bias we have to be mindful of is cultural bias. And this is hitting us pretty hard right now, where they just want to whitewash medicine. You see that right now, especially with like the rise of the Mark Hymans and the Dr. Will Joneses and all the people who supported RFK to get into the White House right now. All of those individuals have cultural bias where they assume that all patients, including Black and brown people, share the same health perspectives. So they're really big on like the keto and the carnivore diet. Unfortunately, Black and brown people don't really do well on keto, especially Black women do horribly on keto. It will really affect our liver and also can burn our hormones and our cardiovascular system out, creates oxidative stress. However, I guess YT males do pretty well on it. So they assume that our bodies are the same, or they assume that we don't feel pain, or they assume that, etc. Now, this is different from studies that come out about our metabolic system and about our immune system. There are definitely some distinctions in health, but there's also more distinctions in our trauma responses and our nervous system dysregulations at the same time. So there's definitely a lot of components when we look at not only cultural, so I classify this as more ancestral, but also environmental. Because the other thing too to keep in mind is that we're still in forced integration. So our nervous systems are never really able to truly relax because we have to, empathize with our oppressors or our abusers. Also to know that the placebo and the nocebo effect, so how your belief systems affect the outcome. So naturally, if I believe in natural medicine's going to work. So for me, I'm totally content with having a placebo bias, because, I believe that natural medicine is the way that my ancestors healed, the way I'm going to heal, and the way that I continue to heal. And so because of that belief that I have, I'm going to seek out ways to be able to heal myself naturally. I'm not just going to succumb to the conventional medical model. People don't realize the power of the mind and the power of the emotions. There was a study that was done not long ago that actually studied placebo. It's pretty fascinating. They told the participants that they were being given placebos, and they, took the placebos, etc., and then they recorded, what their responses were. After this study, some of the participants wanted to continue to take the placebo because they stated that they had a positive impact by them, right? So that tells us already right there that the power of the mind, regardless, of what may work or may not work, if a person's belief system is in alignment to it, then inevitably it will work regardless. Good example of that is, I can't pronounce her name well, but the book is called Dying to Be Me. And it's a book about how she was on literally life support, like on her last 72 hours. And, she changed her mind and decided to live. And so she documents all about it. Very, very powerful. Okay, so how do we overcome our bias? So it's interesting. The more we think we know, the more dangerous we are. Okay, and the reason being is because there is so much complexity and nuance to treatment. And if we already assume going in that we already have it figured out, we're already dead in the water, quite honestly. Because again, we're looking for, what do we see, what do we know, and what can we prove? There's a structure behind this. So it's not based off our feelings, it's not based off our mood. It's actually based off of data, and it's based off of a structure. So we want to approach each patient objectively and with openness, but also humility, because that patient can very easily teach us just as much, if not more, than what we've actually learned already and what we're trying to teach them. So please, please, please don't assume that you know everything. This is definitely a learning process. And this is also why we use a mixed method approach, and we use objective analysis, and we're not just solely dependent on subjective, because if we were just dependent upon what the patient tells us, we could easily, get mixed up in their perception and not necessarily what the data has to say or what the science has to say. So, excuse me. We look at the patient's symptoms, we quantify that, we look at objective analysis after we have determined a hypothesis to prove or disprove, and that is our structural container. And then we're going to modulate that treatment plan over time to see if it's working or not working, right? So this also serves as the kind of foundation of collaborative decision making. So when I was in care plan teams and stuff like that, coming into teams, you never know who's going to be who. You never know if people are going to be receptive to you being there, if people are going to treat you like your redheaded stepchild. You never know. You're going to just assume you're going to be disrespected. And I hate to even say that, talking about bias, but we just haven't come to the place where people really, really respect providers like us. It just hasn't reached there yet. People are very massively uneducated about what we do. And so they don't know the intricacy. They don't really understand it. So they assume a lot. So people assume that all we do is give supplements and run labs and I don't know. So, however, right, we do a lot more than that, as you will know. So we overcome our bias really with the structure, really with science and our scientific method. Now let's look at the provider's responsibility versus your patient, okay? So the provider's role, our role is to guide, educate, support, and keep that relationship within ethical standards and ethical integrity, right? The patient's role is to engage with the information, take responsibility, and then use the information provided to make informed decisions. Where the rubber meets the road is when should a provider intervene versus when. When should the patient be allowed autonomy? And this is kind of the dilemma that we face now with the eroding out the 14th Amendment, which really respects the patient-provider relationship. Now what we've done is we've put the federal government in the middle of your patient-provider relationship. So now the government is in number 2. So provider is 3, patient role 3, provider role 1, patient role 3, and now you've got your government now in the number 2 position. So good job, guys. So how do we find that balance? It's really all about evidence-based approaches. Again, I'm not looking at the data from anybody else. I'm looking for my own data. That way I can back my data up because I took it, I know it, it's in and out, blah, blah. I'm not going to give that power away over to anybody else. And so that gives me my evidence-based approach, and that's my CYA. And then I provide resources and education to empower my patients to make decisions. I never pressure my patients to do anything. I give them all the tools, all the information that they need, and if they see it of value, great. If they don't see it of value, that's great too, but there's really nothing else for me to, I'm not from the show me state, so I'm not going to sit there and try to prove to you and stress myself out, and now I'm teaching you and unsolicited and all that stuff. No, it's fine. If you want to stay stuck, you want to stay unwell, you want to stay, wherever you are, great. That's wonderful. You have my number when you're ready. And that's honestly the conversation you have to have, and the boundaries you have to have. Otherwise, you're going to get worn out because there's so many people that are literally just kicking tires. They don't want to get well, but they want to waste your time because they want attention. They're looking for attention. And if they don't get the attention, they get really crazy. All right, so let's jump into some more role playing. So scenario 1, the patient refuses conventional medicine, but requests holistic treatment. So this has happened to me many times, where the patient is literally terrified of the conventional treatment, and there's been given no alternatives really, or no hopeful conversations. A lot of times with chemo radiation, once you go through it, there's an 80% chance of that tumor coming back. So can be really stressful, and in a lot of cases it's rushed, meaning that there's no real threat, but they want to do it almost prophylactically, I've seen. So it's really up to the patient. You as the provider, though, you are to provide the patient all of the information that you are aware in an unbiased way. The patient gets to decide. So I had a patient that, hold on one second, I'm gonna grab my coffee. I can tell my little energy's fading from my little naps. So right after this, I'm gonna definitely get some sleep. Okay, so I had a patient that she's still a patient actually, a patient who was diagnosed with stage 2 breast cancer. The patient was told that they needed a double mastectomy plus chemo radiation, reconstruction. So pretty severe for a stage 2. If you look on my YouTube channel, our interview together is called Lisa's Story. So if you want to see me and Lisa chat, we rap about her experience of treatment. So Lisa came to me again. She had stage 2 breast cancer diagnosis, and she had been to an initial doctor who told her, double mastectomy and all the things. And she said, yeah, no, I'm going to get a second opinion. So she let me see. I would emphasize with how scary that can be and provide education. Oh yeah, definitely. Empathy is super important. So Lisa came to me and she goes, I don't want to do any conventional practice. I only want to do natural. Okay. So I said, all right, Lisa, well, I need to get all the data, right? So let me get all the data and let's go first, right? So I pulled all of her data and I go, okay, well, it's stage 2, it's slow growing. And, I think I got a good grip on, what some of the causes were. And we kind of we worked through her metabolic health. We worked through, her liver issues. We worked through several things. And we had actually narrowed it down to, we did a thermography scan, and she had some amalgam fillings that had been leaking. She hadn't known about. So they were in her mouth and they were now leaking, and they had leaked down her lymph system into her breast tissue. And her liver, she wasn't methylating properly, so her liver wasn't detoxifying properly. Her metabolism was sluggish, so she was accumulating toxicity. And now from her amalgam fillings, it had leaked and now created these tumors in her breast tissue. So we were able to determine that. We were able to detox that out. We were able to clean that up, right? So here's what I said to her. I said, okay, we can go natural, but we're doing regular CT scans. You're going to your oncologist for your follow-ups, and we're still going to follow the same kind of protocol. You're going to let the conventional doctors know what you're doing, and we're going to monitor you really closely. So, after working with her for about 6 months, we pulled the CT, and the CT was negative. There was no tumors, she was completely negative. So, we were able to address it completely natural. However, right, we did that because we monitored it and because we had her on, a very specific protocol, and she was still being monitored by her conventional doctor, right? So later on even, it looked like, some were returning, and her conventional doctor called when there was only a couple little flecks or whatever in her breast tissue, and they call yet again, sky is falling, double mastectomy. And, we have to ease them down and go through the process again. So, we can't just reject, conventional practice. We still keep them, around, and we still keep them a part of the care plan. But, we include them, but we let them know kind of what we're doing in addition to. So definitely check out Lisa's story if you want to learn more about that. Okay, so scenario 2 is a holistic practitioner disagrees with a conventional diagnosis. Man, if I had a penny every time this happened. Okay, so you cannot technically outwardly go against the conventional medical model because they have a monopoly, unfortunately. However, what you can do, because you are typically the not just the second opinion, usually I'm like the last opinion. So as a response to that, I can look at the various differential. Like, I'll give you an example. And this is just kind of a silly one, but I was scrolling through, hey, bucket of tears. I was scrolling through, TikTok or Reels or something. And I saw this runner, and she was running, and then she literally seizes out. Like, I watch her kind of seize. And so I'm looking at her seize, and I'm like, okay, wow. And so then there's this doctor that goes in there and says, oh, she must have had, a cardiac arrest, and there's this and there's that. And there's, he's going into all of his, differential diagnosis. And I'm looking, and I'm like, that looked like a seizure. And then, it just kind of probably electrolytes and compound or whatever. And so sure enough, it was a seizure. And, I didn't need to go and be like, you didn't know what you were talking about, right? Because here's the thing. Sometimes I can get it and sometimes I can't. It's humans, right? We're all humans, right? And my job is not to diagnose and manage disease. I really have no use for it. I even if the patient has a seizure, right? I still have to now figure out, remember, I'm the medical detective. The conventional doctors, all they are is the firefighters. They go and they put the fires out, right? But once those fires are put out, guess who they come to? They come to me, because I'm the one who's the medical detective who's going to come back after the fire and figure out how the fire started to begin with. So it is going to take a little bit of time, a little bit of patience, that sort of thing. All right. Scenario 3, a patient insists on high force intervention despite low force options. So some patients, unfortunately, they're glutton for punishment, and they are so conformative to the conventional model, and they're scared. So I'll give you an example. I had actually a couple, and I work with them, and I taught the wife, how to clean her liver out, her gallbladder out, keep her diet. We flushed her gallbladder flowed great. She was doing great. Everything was good. Her husband had prostate cancer, but it was very slow growing. We were on active surveillance. We were addressing it. And, again, these patients, they were doing okay, but they were kind of slow. They weren't quite following through with the protocols. They'd get, they would skip appointments. You could just see it kind of coming. And then all of a sudden I get an SOS phone call. Dr. Steele, stat, you have a patient in the hospital. Okay, so short story. I'm not a real stat kind of doctor, right? I'm not an ER doctor. Never have been, never will be, not my bag. Why? Because I don't want to be in a reactive state. I already have, my nervous system's already jacked up already. The last thing I need to be is, ER and Grey's Anatomy 24/7. So anyway, occasionally I get a stat call. So I get a stat call from a patient. Oh my God, this patient's in the hospital. I pick up the phone. I speak to the patient. What's going on? The patient's having their gallbladder removed. What happened, patient so-and-so? So what'd she do? She stopped eating like she's supposed to. She started stressing. She pretty much stopped doing any of the things that I told her to do, and then kept neglecting until she got into the point of getting into the ER, and she didn't call me ahead of time. She let them remove her gallbladder, and she was calling me afterwards, I guess, to lick her wounds and, I don't know, emotionally support her or whatever. I don't know. I kept it really short because why? The patient is insisting on a high force intervention. And a lot of times patients will go to their conventional doctors and get a little bit of information and want to bring that back to you to sort through. No, we don't do that. I'm not taking another doctor's information, especially one that is not trained like I am. We have different practices. So I don't want to be triangulated. And you have to be mindful because patients will try to triangulate you with their other providers, meaning that they'll try to kind of pit you against them to try to forward, their health. And you have to be able to set healthy boundaries and go, yeah, I'm not doing that. Do that, play with your mama, not me. Let's see. Yeah, so a lot of times when they insist on that high force intervention, it's just because they're highly reactive and they want that kind of emotional soothing. But you also, part of your role is to teach patients how to, right, soothe themselves emotionally, because you don't want to create dependency and transference, right? So if that patient has abandonment wounds, which is driving their anxious attachment, all right, and then now you're their provider and you don't have your, self-organized and in check. Now every time that patient calls and you're self-abandoning and, running to Operation Save-A-Ho, that's not going to help anybody. That's not going to help her. That's not going to help you. That's going to actually be unhealthy for both of you. So you can see that it's really important that you approach each case ethically and responsibly. There's a balance. It's not all, natural health or bust, and it's not all conventional medicine or bust. I'd love to say one or the other, but it's just not. Each individual patient is different. Each individual patient's unique. Each individual patient's going to come to you with all different aspects. And again, it's up to you to sift and sort and organize it. It's complex. It's not easy. So some of your key takeaways here are you really want to ensure that with ethics, you're providing responsible, patient-centered, holistic care. No nonsense, right? You're not selling them, a bridge in London. You're not, trying to, offer them the moon, the stars, the world. You're not telling them that you've got some obscure, herb that you've dug up from, Africa or whatever, and now it's going to heal them, okay? You're not a scam artist. So, you may grow, a little bit over time, but what'll happen is you build a practice of integrity. After 20 years, I have a practice of integrity, responsibility. And there's some people who are hot at me, boy. I used to have one patient, every year she'd write me a bad review. I swear, I think she'd set an alarm on her phone. Every year she'd write me a bad review because I wouldn't just let her do whatever. I said, no, I'm sorry, you can't do that. If you do that, if you eat this or you eat that or you do this, you do that, it's going to harm you. And you're coming here for me to help you. So if you want to get well, you're going to have to stop doing this. Oh, yeah, no, she was very upset with that. So every year, like clockwork, I would get a hateful Google review that would say all the things about how horrible I was, right? Until eventually she went to other platforms and eventually I got tired of it. And I said, all right, lady, we're going to do a cease and desist here. You're going to need to deal with yourself, right? You're enough. It's been 5 years now. I've let you, go on these long rants on Google for, the last 5 years. Now it's time to hang it up, right? This is not that serious, right? So it's all about setting those boundaries and setting those limits, right? But here's the deal. Data and analyzing of data proves all. Data has always been my CYA. So data is what got me into doing more legal cases where I would get phone calls to pretty much, be like a medical, medical expert on a case, especially against other naturopaths who were doing things that they weren't supposed to. And so looking at the actual data, analyzing the data of the case, and then determining. So like I said, if you train with me and you go do something crazy, if you don't follow the practice and follow how it's taught, don't come looking to me to save you, because that's not what it's there. We have these ethical responsibilities and we have data structures in place so that we can provide and execute healthy care. Naturally, we have to look at the stages of change. So this one can be really hard for a lot of people, especially if you're a wounded healer, because you so desperately wanted somebody to help you, heal you, etc. So you tend to have this blind spot where you think that, everyone and anyone wants change. And so trying to help people who don't want to help themselves. You can't do that. It's an imbalance of power, right? Remember, you cannot save people from themselves. I don't care how much you love them and care for them and how many protocols you give them and how many supplements. When my former husband, got sick with cancer and finally would allow anybody to treat him, it was just insufferable. It was so difficult. Mostly because he didn't want to heal and he didn't want to get well. But, the other piece is that he really just, wasn't ready. He was in that, pre-contemplative stage of change. And so literally living off of my vital force life energy, right? And so that was some really powerful lessons for me to learn, just about where my lines begin. And no matter how much I care for an individual, I can't put my own health on the line to be able to save someone. So really assessing those stages of change can really help you to be clear about, when a good intervention would be or when a good time to step away would be. You also want to always recognize your biases and the ethical dilemmas that come up as a response to that, remember, it's not natural all the time, as much as I'd want it to be. There are going to be patients you're going to see that are going to be on synthetic medications. And there's going to be some patients who absolutely have to be on synthetic medications. There's some patients that are going to need to be on psychotropics. There's some patients who've had structural issues with their heart who need to be on, hypertensive medications. There's autoimmune cases that have to be on stabilizations. There's all kinds of things. Pharmaceuticals are not evil, okay? They are stabilizers. They help to stabilize the patient when the health of the patient is so compromised that we need those synthetic stabilizers. So, even though we appreciate holistic medicine, and this is why we talk about the therapeutic order, so when to use what, right? And also, I'm not reactive, so when a patient comes in, I do a consultation with them, I assess a case, I then sit with that, right? I get the data, I assess the data, then I look at, their subjective, then their objective, and then I create a plan. It's pretty much over the span of like 2.5 appointments. So I give myself some space and some time to recognize any biases, to recognize any ethical dilemmas. If I'm moving too quickly, if I'm rush, or I'm allowing the patient to rush me, guess what? I'm not really going to be in alignment with my ethics or my ethical responsibility because I'm swayed by the patient. So you really have to have a strong constitution and really good boundaries in this care, because think about it, a lot of patients are unwell and they're desperate, and I'm usually, again, I'm not like the first or second opinion, I'm usually the last. They've been to every doctor underneath the sun, and they just so badly want to heal. And so I really take that responsibility seriously. I don't give them information that I can't verify. I don't overpromise. I don't over-deliver. I try to really keep that in balance. Because here's the other thing. And sometimes patients will do this too on the flip side. So let's say I give a patient a protocol to do, okay? They don't do the protocol, but they want more from me. So now they go, I told them that they need to drink water and watch their protein, but they haven't been doing any of that. But now they've got new labs that they want me to review. Okay, I just reviewed labs before, right? Nothing's really changed, and we've set up this protocol, but now they're not moving forward with that. But now, instead of actually doing the work, they want to leverage me to do their work. Okay, those cases never work out well, because just because they're paying you doesn't mean you can do their work for them. It's not how that works. And some people will assume, well, because I'm giving you money, then I'm sure it'll work out. Well, no, just because you're giving me money doesn't mean that you're automatically doing your work. You're not. And just because people pay money doesn't mean that they're ready to do the work. And I know that's confusing too, because you're like, why would anybody trust me? People do it all the time. People have paid me money for me to prove to them that they can't get well, and you know what? Your wish is my command. I'm not going to stress myself out. I'm not going to, be in the resistance with you. I'm not going to be in the tug of war. If you're not ready to get well, that's on you. It has nothing to do with me. My responsibility begins and ends once this information leaves my mouth. So if you choose to pick it up and take it and do something with it, great. But if you choose to abandon it, and now all of a sudden you want to become a researcher, and now all of a sudden, what I say is just hogwash, I always found that funny. People go to conventional doctors. Conventional doctors will tell them the most craziest stuff, and they'll be like, okay, yeah, sure, no problem. As soon as they come into my office, now all of a sudden they're PhD level researchers. And now all of a sudden, they know all the things. I just find it interesting. That bias, bias is kicking our tails. So ultimately, our goal is to empower patients while maintaining ethical standards. So that's really the magic, and the sweet spot is we maintain our standards, right? We don't deviate from our standards while we're also encouraging, motivating, educating, empowering, and holding our patients accountable to get well. All right. Does anybody have any questions? This week you should be tracking your pH levels. Remember, your salivary pH level is your digestion. It should be around 6.8 is a sweet spot. That's how you're breaking down, digesting, assimilating. That's really a collection of what you're eating. Best to take it first salivary and urine of the morning. Urinary is oxidative stress, how you're detoxifying, okay? Same thing, 6.8 is where it needs to be. So by now, you should have completed your nutritional assessment questionnaire, which is your subjective data. It's all of your nutrient deficiencies and all the symptoms thereof. You can see which organs are most affected by looking at the, mild, moderate, or high. So now you've isolated that down. We've talked about priority. We've got to work on the digestive system, healing the digestive system from the top down. So it's what you're eating, breaking down, digesting, and assimilating. Thank you, Melanin. And so that's really what we're going to be continuing to work on. And then so what has already hopefully started to happen is now you're going to have some resistance start coming up. Okay, so it's going to start coming up kind of intensely over the next couple weeks. So as we move into part 2, now we're we're almost past, after today, we'll be past the part 1, which is really the setup, our foundation. And now part 2, we're going to get to work. So now moving into the next 4 weeks, we're going to get to work. So now we're going to work on our food. And we're only going to be working on food for a week. So that's not a lot of time. We're going to be working on our stress management, not a lot of time a week. Then we're going to be working on our movement, our physical exercise. Again, a week, not a lot of time. And then lastly, we'll touch on some remedies and stuff like that. Again, a week, not a lot of time. So these next 4 weeks are going to fly by. You may not think they will, but rest assured they will. Because now we've left kind of the foundations of it, and now we're practicing. So now all the breakdowns are going to happen. All the yeah buts, what ifs, I don't want to's, I'm going to quit, this is too hard. All of that is going to come up. So don't run away. Don't go into hiding. Don't stop reaching out. This is why you're in your communities, okay? To be able to reach out for support. You can reach out to the chat and ask me a personal question. You can reach out in the community, but definitely keep moving forward, right? Keep going, forget the rest. What do they say? Do your best, forget the rest, right? So what we're going to be doing is reviewing the recommended readings. I'll start putting in next week's information in there. We're going to start applying these ethical strategies. So we're going to start kind of thinking about, how we're approaching people, how we're approaching ourselves, using these ethical standards. Are we pushing? Are we forcing? Are we being in the moment? You're going to join the community discussions. I definitely have been seeing some people kind of go, hey, I'm starting to get it, but man, it's a brain shift between this conventional practice and holistic. So definitely be patient with yourself with that. And then watch the class replays in the learnings tab in case you missed it. So this is the learnings tab. So this is the holistic lifestyle community. This is the left side of the room. And so there'll be a discussion tab and a learning tab. Once you're in the learning tab, there is this course, Intro to Holistic Medicine. Once you click on the course, it has all of the course materials right in there. And so you'll be able to see the replays and watch all of, the information and read any of the information that's provided. Your discussions will need to go under the discussions tab. Notice right here, like I put welcome to week 3. So every week I'll put the new information in. So usually it's on the weekends I'll post it. If not, no later by Monday is usually when I post it. So I'll be working on it probably later on this afternoon. I'll take a little nap after this class and then I'll post it for week 5, which we'll be moving into nutrition. This is week 4. We kind of just finished out ethics and finished out our foundation. So next week we move into nutrition. Definitely the pace is going to pick up over the next 4 weeks. So keep that in mind. And then just back to the beginning. So remember, this is 2 totally different practices. One is very reactive, one is very proactive. One has only a couple tools, the other has endless amounts of tools. One isolates the body as these individual illnesses that occur, whereas in holistic medicine, we look at the whole unique individual. Hello, solo. Also, the patient's role is also passive in conventional medicine, whereas in holistic medicine, we put the patient on the court and we're working with the patient. It's a proactive instead of reactive relationship. And our focus is prevention and lifestyle changes, where in conventional medicine, again, it's mostly just the body's flawed and it breaks down and it's always going to need this external intervention. Whereas in holistic medicine, we believe that the body was made to heal itself and can and will heal itself when given the right environment. Even though we use the same tests, conventional medicine is very reliant on tests and scans, and pharma, they don't always effectively utilize their tools. Whereas in holistic practice, we pretty much use everything, including nature, to be able to help us determine what's going on. And so that really integrates all aspects of the human being in holistic medicine. That's why we look at the relationship, whereas in conventional medicine, it just separates us out. So once again, this is concluding our week 4 of Intro to Holistic Medicine class. If you haven't registered and still want to, there's still time. It is a self-paced course, so we do accept registrations throughout. Just click the link in the bio, scroll down, and fill out the form that says Intro to Holistic Medicine, and you'll choose your cohort experience. There's a holistic health coaching cohort if you want to do this as a profession. If you want to treat yourself and your family, the holistic lifestyle community, or if you want more of an Afroindigenous blend to it, we will start getting deeper into that as time goes on. And so this is the end of ethical decision making and data-driven holistic health. I am Dr. Steele, and I'm going to sign off, go get a little nappy nap, drink some water, probably eat some ice, and relax. So, all right, guys, I will see you. I actually think I'm going to do the stress webinar that I wasn't able to complete on Thursday. I'm probably going to do it tomorrow, just so I get it out of the way, because next week, again, back to the grind. So, and it'll be kind of fast-paced now that we're getting into nutrition and that kind of stuff, because people have a lot of questions when it comes to that kind of stuff. So I'll probably do that tomorrow. So probably around 1, I'll send out an email and let everybody know kind of what I'm up to. So we'll do that, and then we'll be back into morning flow on Monday and back to our normal schedule next week. So, all right, guys, thank you so much for attending, and